Folks, we are preparing for our next meeting here on Zoom. This is a case study today. Waiting for folks to come online with us. This is going to be a guest case today. Our guest presenter today, Dr. Marc Heller, is going to join us and present a case on anterior hip pain of due to an impingement of an abdominal nerve. So that is one that many of you, including Brandon Fromm, who was just kind enough to get in touch with me, have seen in practice. And that is, Brandon won't be able to come in today because he's on he's seeing patients this morning. But that is one that we see quite often in practice. There's a handful of nerves in that area. And Marc's going to talk about 2 or 3 of those today. As a matter of fact, he's in the waiting room, so I'm going to go ahead and admit him. Good morning, Dr. Heller. Let's unmute your mic and be aware that you are currently being recorded.
Okay.
There you are. Greetings, sir. Oh, you're gonna get yourself all pretty. I don't know. I like the you were pulling together the colors there. I appreciate the
I gotta show off that I still have some hair, you know.
How you been, my friend?
I'm good. I'm good.
Yeah.
You know that I had a very profound week. I guess it started last week with uh, the woman that I worked on that I helped so much, who had been suffering for so long, and she was very grateful. And then it, I've been a writer for a long time, and I haven't written a whole lot in the last couple of years, and um, it came to me that I'm not retiring anytime soon. I've got this perfect gig, 2 short days a week, and it just keeps my brain going. And then uh, it it's really so. I got back into writing this week, and I wrote up that case, and that was um, fun, and it's great to be able to share it. And the other fabulous thing is sharing with my son Aaron, who's a uh, family doc DO who's getting into manual therapy and cranial, and we have so much to share. I just love that. It's such a
That's
gift.
awesome. That's
It
awesome.
is.
We've got some parallels there too. My son is as you know, is in his 4th year of med school, and he's looks like going into internal medicine and global health sort of combined. So yeah, he got in touch with me a little while ago when he was on a family practice round and was like, "Is it okay if I send that fix your own back course link to my patients?" Because he's like, everybody that is coming in has low back pain, and we don't have any jobs to be able to deal with it. So he says, what's the evidence on that? I'm like, bud, the research hasn't been done. I said, it needs to be done. I don't have the bandwidth to do that. And he's like, well, maybe I can help you on that. So we'll see. Well,
That'd be great.
yeah.
The other thing that happened this week is um, I listened to a fabulous podcast on hidden brain, uh, and I'll post the link later. But it was about um, open versus closed, and you know I, that thing about evidence. It's like what we do has such variability to it. It's really, really hard to get clean evidence. And the decision points are so, um, there's so many decision points in what we do with a patient that are really, really, it doesn't lend itself to the same kind of research you would do for a surgery or a medication. So I don't
Yeah.
know, it's tough.
Yeah, I would agree on that, Mark, and I'd add that this was kind of this whole process of us talking today about this particular case and how we're doing it. As you know, when you first submitted the article, I punted back an alternative version to you.
Yeah.
Was a case report style, and the whole reason that I did that was because had just come off of a conversation on evidence-based chiropractic online, where um, Jerome Fryer was kind enough to come on, and Jerome was kind enough to come on and um, point out a podcast that I have recently done with Ryan DeBell on NeuroCentric approach. And one of the people that were on the site immediately came in without even looking at any of that and said, maybe we're just jumping on to accepting these approaches or processes and everything without evidence, and maybe that's a cart before the horse. And I agreed with him. I'm like, we do need to get some evidence out there for this process. And the way to do that is the clinician scientist kind of model, which starts off with case studies. And there's a standard format for that, which I agree with you completely in our dialogue back and forth on it, Mark. It drains it of so much personality and readability, but still, because it is putting it in, because it's putting it in a package that can be compared to other similar packages, it builds a foundation that can then be added onto with case series, and then perhaps can grow from there to larger areas in the evidentiary base. And I want to share with you guys that have jumped on here early. Some of you know that when I teach, I like to reward the people that come on time with a little extra bone. So I'm going to share screen with you and show you how I got that case presentation that I sent to you, Mark. And I want to show you how easy it is. And this is going to be incredibly, I think you should be not afraid, but you should be wary of it, and you should use it. So here we go. I'm going to share screen. Give me a thumbs up if you're able to see my screen. Cool. So let me go over here to my ChatGPT account. Okay. So let's say you want to write a case report. You don't know how to write a case report. Well, go over here. Just use Google, good old-fashioned Google. And I put in a request for a format for writing a case report for a medical journal. And I found this National Institutes of Health article that is public facing. Okay, everything is not, it's open access is what I'm trying to say. I can download that particular article, and then I can go on ChatGPT and I tell it, Help me write a case report worthy of publication in a medical journal. Use this file as a reference for the clinical data, which will be imported to you. Okay. Now, that's what I did. Now, the article that we're going to discuss today, this is Marc's write-up of it, and it's done in Marc's inimitable, colloquial, wonderful, friendly voice that all of us have known and loved him for so many years in his writing for dynamic chiropractic. But that particular way of writing and my particular way of talking about these things doesn't fly for a journal presentation. However, if you go to the NeuroCentric Approach blog, by the way, guys, this is where it is right now. That article is sitting over there on the blog at NeuroCentric Approach, and I'll add this video when we're done with it here today. But that I just went in, you can see where I selected that and I copied it, and watch what happens. You guys can put a split screen, look at that article on one screen, and now look at what happens when I tell ChatGPT, now use the formatting tips noted in this article to rewrite the previous article, the one that I just imported from Marc. All right, so there it is. There's my title. Chronic groin and low back pain managed through abdominal nerve release techniques, 57, an abstract, introduction, case description, clinical findings, intervention, follow-up, discussion, and conclusion. It points out that there's no references. It puts on at the end a note on patient consent, ensure that the patient confidentiality and obtain consent for publication of the clinical details. It notes that the revised case report follows Sun's recommendations in 2013. Everything is there in a skeleton. Now, what you do not want to do is ever use this to submit a case report, right? But this gets you over that initial writer's block of like, all right, now I got to go put all these pieces together to put this together and then try to submit it. So this is a way of using the current technology in a way that is ethical, that you can then plug in your own details on it and make it work. And what I'm looking for, hopefully from you guys as well that are utilizing this approach, that you can start putting together some of these. And the two areas that I am most interested in or what Marc's talking about today, which essentially is a little bit of a fleshing out of some of the elements of Main syndrome, and then another fleshing out of some elements of Main syndrome as superior cluneal neuralgia. There are no papers in the literature out there on manual therapy for superior cluneal neuralgia. And you guys are treating it. I'm treating it. I know Marc's treating it, and we're having a pretty good result. Not everybody gets better with it, and that's where we need to rely on our colleagues that are probably using needles and things of that sort to help out with that. But we need an evidence base for that, and I think a case series would be real nice. So here is a way that you guys could put that together. If this doesn't appeal to you, then just write up your case. I've even tried this using Jane. Now, I do not, and this is important for patient confidentiality, I do not import a Jane file into that. I take the Jane file, I export it as a PDF, I then go on Preview or the book app on my Apple, and I redact all of the patient information so I make it clean that I can then import that. And I don't even have to do any changes to my existing chart note to get it presented in this particular way as a case report. So that could get you started, or at the very least, it could get us started, and you could punt it over to me and I'll start putting these together. And then I'll kick it back to you and say, hey, I need more information on this. I need more information on that. But then you might wind up getting some journal credits for that. Aaron, you're working with students there at Western States. this might be an option for students to get some writing exposure. These particular articles that are written, at the very least, I'll publish them on the blog, and now you've got a writing credit that you can refer back to. You can put it on your website. Now you've got some marketing material. You can take the same thing, you can put it in front of a physicians group that is in your community that you're hoping to, to get some collaboration with and possible referrals. So that's just some ideas that I've been having over the summer while I've been away from you guys, and out gallivanting around the world, and enjoying some quality time with my wife. Does anybody have anything to talk about before we hand the show over to Marc to take us through his course?
So where I want to start, so one thing, Philip, the particular case that we're presenting today involves more advanced manual therapy skills, being able to reach deep into the abdomen. But most of the work that I do for flank pain, buttock pain, iliotibial band pain is quite a bit more straightforward than this, and basically involves using primarily dermal traction and home dermal traction with suction cups that the patient does, and some manipulation of the thoracolumbar junction. And I am going to write up a couple case studies on those simpler cases. But I want to step back a bit, about 5 years, and I knew that the cluneal nerves were important, and I knew Manx syndrome was important, but I was getting lousy results. I was getting 50-50 kind of results. And I had colleagues who were doing something that was called NeuroProlo at the time, which was injections of 5% glucose solutions into irritated peripheral nerves that were near the surface. And they were getting better results than I was at the time. And then you and Dean came up with YAP, yank away pain, the old name for what we now call dermal traction. And I started using that, and I started getting way better results when I thought the problem was a Manx syndrome related thing. So it starts there, and then I've been using it for a very long time here. So that's an important piece. Let's a mini case of this. I have an 85-year-old woman. She's coming in for one problem, and she says, "Oh, I'm probably going to have my left hip replaced or revised because it was done 19 years ago." And I said, "Well, let's take a quick look at your hip." And I don't have new x-rays, but I go through my basic hip exam, check range of motion, make sure she has function in her quads and hip flexors, and all those are okay. And she shows me her most tender spot, and we find a couple spots along the posterior fibers of the iliohypogastric nerve. Maybe they're called lateral, maybe they're called posterior, but basically they're right in the mid-axillary line, just below iliac crest is where I find that hot spot. So we stand her up, give her a suction cup, have her do DTM to that as she goes back and forth, and lo and behold, that tenderness is gone. And she's a good patient. She's going to go home and do it. The patients who don't do anything are more frustrating, of course. But as we all know, the more you attract the people who want to do the work if you build that part of your practice, which I certainly do. So let's go on to the case of the day here.
Yeah, let's jump into it. Let me kind of introduce it briefly for you, Marc.
Sure.
Marc has got a 57-year-old female that presents with right anterior hip and lateral flank pain and some buttock pain. And he's seeing her on referral from his colleagues at his clinic, where they have several chiropractors working there. And this is in Ashland, Oregon. For those of you that are reading this later, if you're in the general public and you're in that area, then go see Mark, and he can hook you up. But this particular patient had originally presented with a sciatica and pain down into, I believe, further down the leg. Did they not, Mark?
Yeah, um, it was buttock pain rather than true sciatica. And there was this component of anterolateral hip pain in
Okay,
addition.
so
And
you've
and
got
the
her.
one, go ahead.
Again, you guys can, if you want, I sent an email to you again about an hour ago that has a link to the article that's up on the NeuroCentric Approach blog. So you can pull that up if you like. I'm not going to go through and read that. That would just be silly. But Mark, now take us through your conceptualization process when this patient walks in and you start working through things.
Well, the first thing I did was I wasn't sure whether my colleagues had ruled out sciatic nerve involvement or femoral nerve involvement, so I wanted to check that. So I do a straight leg raise, um, add the foot dorsiflexion. That's completely negative. That doesn't remind her of her pain. I turn her over. I do a femoral stretch test. That doesn't remind her of her pain. I flip her on her back again, and I go through a hip range of motion. And there's three things I do there. I want range of motion. I'm particularly interested in internal rotation. I'm going to palpate um, over an area. I basically bisect the inguinal ligament, drop a centimeter or so below that, and push in there, which basically is over the head of the femur. And that's often very tender. And the third part of that hip test is a muscle test supine of the hip flexors at about 30 degrees of flexion. This all, by the way, is from chiropractor Lucy White Ferguson of Taos, New Mexico. And she was negative on all the tests that I do for a functional hip impingement. So, okay, so it's not any of the things I think it's going to be. And then um, now I get out of my way. I've done my left brain thing. I just I happened to put my hands on the front of this lady, and she's a big lady. But again, the visceral manipulation skills allow me to feel deep into the abdomen without poking deep into the abdomen. And I feel something, basically in the upper lumbar from the front, just lateral to the psoas. Okay. And uh, this is not a skill that most body workers, most chiropractors have. A lot of people work on the psoas, but very few have learned to feel. I mean, the psoas is a deep structure and all, but people tend to go in a different way than Jean-Pierre Barral teaches. So Jean-Pierre Barral has this approach using a flat hand. He calls it local listening. Initially, he's just running his hand gently down the abdomen and saying, where am I attracted? And I do that, and then I'm attracted to this place, you know, not low, but just below the diaphragm. And then I put my hand there, and there's something not happy there. And then again, a subtle skill of knowing how to release that. And what I did, I have called engage, listen, follow. And when I Googled my own name and engage, listen, follow, I found an article I wrote in 2001, 23 years ago. And I totally got a kick out of that. Because that article basically says a lot of the stuff I'd say now to those who want to try to do this kind of stuff. And one of the things about it is that you have, it requires really paying attention in the moment and not forcing things, but allowing things. And so anyway, I did my engage, listen, follow, release, and she got up and said, "Son feels better." And a day later, she says, "I feel the best I've felt in the whole month." And I follow up with her a few days later, and now I get a little more formal. I've already ruled out sciatica femoral neuropathy hip, but now I palpate her, the front just below the ASIS, and there's some tender spots there, which, and I don't know what you'd call them, but anterior lateral femoral cutaneous, uh, whatever it is. So what I did there is I take a little piece of paper tape and I stick it on the spot. And again, um, I want to be sure I can go back to the same tender spot. So I always mark things. I'm writing on people with a wet pen all the time, and I'm using that. I just want to know I'm going back to exactly the same spot when I'm done. And that's, what you go through your drill with index movements, and Craig Levinson has clinical auto profile. And when I can get a range of motion, I do that. But sometimes I get a little lazier or a little quicker or something. I just want, where do you hurt? If I can touch where you hurt, I may be able to affect that. Not necessarily by working more where you hurt, but by tracking that back. So again, I do a similar ELF to the upper abdomen, and this time I explore the medial border of the iliac crest. And that's where the iliac hypogastric nerves go through um, go through the abdomen. They do have a little bit of motor supply to the abdominal obliques, and you can touch it. They get closer to the surface, just medial to the ASIS. So that was another place that I did a gentle nerve release. It wasn't exactly DTM. It's more this directional myofascial release stuff I do. And at that, 2 days later, she's back doing her 2.5 hour vigorous workout she couldn't do all month. And she's a happy person, and it's like, yeah. And there's two links in this article that I wrote that Philip was helpful to edit. One is a link to back when the dynamic chiropractic allowed me to do 2,000-word articles, a whole link about this kind of abdominal work when I first did it. And the other link is that 2001 link to the basic concepts of doing low force work. So I don't know what more I can add to that.
That was good, Mark. A few comments there. I think all of us can relate to your sentiment that, and certainly towards the end of the week, your, as you put it, your left brain kind of stuff. You kind of like, just screw it. You just put your hands on people. I mean, Justin was really good at that. Justin was really good at just putting his hands on and being guided by where the hands went. Now I just put a link in the chat that you guys might want to check out. This is it's called spinal segmental sensitization. I've mentioned this before. I learned about it, I think like 2015 or so. I was speaking at University of Illinois with a bunch of highfalutin body workers there. And Jay Shaw, who many of you know, I got your message there, Brian. Thanks, mate. It's good to see you dropping in. But I got a Jay Shaw, who many of you know was one of the first people to actually do needle dialysis on a trigger point and measure changes in the local histochemistry in that area. And subsequently, Jeff Bove and Milton Cohen and John Quentner kind of blew that out of the water. But one of the groups that he was mentioning were these people that developed this thing called spinal segmental sensitization. And there's a whole bunch of physiatrists. And, I heard him talking about that, and I'm like, this is Irvin Core's facilitated segment therapy or theory. And the way that they were, I remember they had some videos that I've never been able to find again, because I think most of the people that were associated with this at that time, I think most of them have actually passed away. But the videos that they showed, they were using scraping for using a paper clip, just the end of a paper clip, just a pointy end. And they would lay the person down and just kind of pull it across multiple dermatomes in the abdomen. And then mark the area that the patient had sensitivity in. And you could even see on the video where the skin and the muscles in that area where they would flitch and fasciculate a little bit when they pulled that through there. And then they would take just like you, Mark, with a ink pen, they would mark the areas, the boundary areas of the sensitization. And lo and behold, you'd wind up with this lovely little dermatomal map. And it, would bring them right in on those particular areas.
Hey, Philip, we've actually been, after doing a factor course this past summer, I've never taken one, and Todd Riddle's a great guy and teaches a great course. It's interesting because he uses a pinwheel. And so we started playing around with it in the clinic and doing a pinwheel. And it is pretty wild to see that dermatomal distribution. It's pretty cool.
Yeah, you get it hones you right in on the area of choice. Now, more in line with what Mark's advocating for, which I would advocate for as well. Trust your hands, get good with your hands, right? So here's the way that I've gotten, again, from the NCA work that we're doing, we try to go from superficial to deep, right? And Mark's describing a process that Baral is working with there too, of being non-offensive to start with. You put your hands on somebody and just kind of get a sense of how things feel, and then a little bit deeper and just get a sense of what the tissue is there. And you can go as far as you want on this and quantum mechanics and who knows what is going on here when we make these connections that makes you want to find that area of interest that Mark was talking about. And the way that I really have found to very quickly get in there on that is, one, from the visual portion, the patient's doing their cardinal ranges of motion. I'm usually going to see this on a twist in my experience. So the patient does flexion, they do extension, they do a lateral bend, and when they do a twist, one of the twists is off. So their rotational range of motion is off. And I ask them if I can put my hands on their flanks, and I'll just lightly put my hands on their flanks as they twist. And I'll see which of the four quadrants, 2 on the front, 2 on the back, feels like it comes to tension first. And then I'll just apply a little light dermal traction right in that area and see if their range of motion opens up. So that localizes me to that area. And then I'll have the patient do whatever their index movement is. Maybe the patient says squatting deeply is where I feel the pain, or stepping up onto a high box. So I'll have them do that, and then I'll lay them down on their side. Now I do an input. I go in and palpate, deep pincer palpation, and just kind of lift the whole abdominal wall and see if I can find a track, what classically we were taught as that taut band, that we're looking for as a myofascial trigger point, which I'm suspicious is really a neural tunnel of these involved nerves in the abdominal wall. And usually the patient I find is like, whoa, that's really tender. And then I'll have them twist on the table back and forth. So one arm goes one way, the leg goes the other way. What am I trying to do there? Internal and external oblique. Think about the biases of those muscles overlaying each other. And I'm trying to lift, using dermal traction method, lift that tissue in that area while the patient moves. So that's borrowing from factor that Aaron was talking about. So as we do that, the patient usually will find that it's less tender. Then we stand them back up, repeat the index movement. There's your clinical audit process. And often you've got a significant change. What else have we done? That twist in the cardinal exam, the cardinal planes of motion exam, that's top tier SFMA, right? So we're looking there, and oftentimes when they do that twist, and it's often not painful. So there is what, from an SFMA perspective, they would consider your high payoff area. Why? That's your dysfunctional, non-painful thing that you're trying to work on from that particular model. What I like with what Marc's doing here, this is a lovely, lovely demonstration that the inputs don't matter all that much. He's been working out there longer than any of us. He's 44 years into doing this. He knows how to use his damn hands, and he can use them 6 ways from Sunday in a variety of different methodologies he's been well trained in. And he's going to use those inputs the way that he feels the most comfortable. And what I'm trying to do with the NCA stuff is to allow a framework that you can use your own inputs, whatever you feel comfortable with. It could be factor that Aaron's talking about. We had Doris and Brian on here earlier that both are acupuncturists as well as DCs. It could be needle work that you're doing in that particular area. It's agnostic to your inputs. But what we're trying to do is come over the top of that with the conceptualization of, first, if you've got pain in an area, is there neurology that is driving that pain presentation? And if so, then that probably is the first place that you should be working. Comments from anyone? Welcome on, Jerome. Nice to see you again, man. Go with it, Marc.
So I just want to throw in one more thing. Back to the spine. The area that the nerves that we're talking about for this case and all of the Meng syndrome variations is always coming from, call it T10 to L3, more likely T12 to L2. But almost none of the people who have this problem complain of back pain. Occasionally, oh, my flank's a little tight, but it's not, they don't usually have pain between T10 and L2. But, and this is back to Meng's original writings, you're looking for, are they tender to the touch in that area? Are they stiff in that area? Are the muscles tight in that area? So I always like to do that exam, and typically I get the best results with pushing a spinous from right to, if it's a right-sided pain, I'll push the spinous right to left at those levels, and I'll find tenderness. And he talks about going over the facet joints as well at those levels. So you do want, what Meng did was 2 things. He would inject those levels with anesthetic, or he did a manipulation. And the manipulation in what we would call now would be in the direction of ease. Meng was very skeptical that chiropractors took field restriction. But however you do it, it's useful to give some input up higher there and find a specific level. And if the patient has the flexibility to reach with a suction cup up that high, I will have them do DTM there as well as DTM on the specific areas on the buttock. I know I'm following up all this stuff you were talking about in the abdomen, which is great, but this is, I just don't want to, I'm a chiropractor. Where the heck did this pain start from?
Yeah.
You know?
Yeah, exactly. And according to the model and what we're playing with NCA, as I said a few times, you find a hot nerve somewhere in the periphery, track back upstream and keep going upstream until you run out of hot nerve. So you keep going back up because the symptoms typically are downstream from the original issue. And therein we kind of go back and grab some of the old writings of double crush hypothesis and that kind of stuff. So you go back and you find a little tenderness on your palpation of the spinous and the interspinous process, interspinous spaces in those particular segments in the spine. Hey man, I can manipulate that area a few ways, and I generally will. One of my favorites is one of my mentors, Dr. Art Walker, Alex Bellingham's dad, and Alex is sometimes on here with us. But he showed me a delightful, easy way of getting that TL junction in a seated posture. I use just a rolled up bath towel or rolled up a hand towel, sit behind the patient with their arms crossed like this. They drop. I give them a big bear hug, do a little tissue pull, and a quick little release on there. It's way easier than trying to get the TL junction in a supine position from my experience in trying to get a flexion movement in there. And then I'll work all the way around that. And you guys that have done the lower quarter course with me, we've got some really tasty mobilizations on the hip that are pairing Cyriax's ideas about capsular restriction with the published evidence on what nerves innervate what portions of the capsule. So we are literally trying to theoretically get in and mobilize the hip joint in a way that takes into account those specific nerves. Mostly here will be the femoral and the obturator nerves. So I'll do manual therapy, usually DTM or TNM, transverse nerve mobilization of those involved nerves, and then try to get down to the hip capsular mobilizations in a sideline position with those patients.
So I appreciate what you were talking about in the abdomen a few minutes ago about just grabbing tissue, wiggling tissue there, and seeing where the restriction are that we're hypothetically working with the iliohypogastric inguinal nerves as they come through that musculature. And I think that's much easier to do than the weird stuff I do way deep in the abdomen. So I think that's useful.
Yeah, the visceral manipulation stuff is certainly a learned technique, and it does take some subtlety and some practice with it. Mark, as I said on here before, I think you and I first met at George Roth's tensegrity therapy course in Portland when I was still a student. And that was my first sort of introduction to this idea of, almost of laying on hands. And I can remember being, at that point in my particular training level at that time, I was like, you got to be kidding me, man. There's no way I'm going to be able to feel that. Mark, you want to field that?
I couldn't read the whole question. Could you read it to me?
Sure. Brian's put in a question. With this case, would you still screen with McKenzie positions, like a lateral side glide to rule out the spine, even though the femoral and straight leg tests were negative? Awesome question, Brian. That is an awesome question, and goes back to what I was saying, that the inputs are, it's agnostic to input, but to a certain extent, it's also agnostic to your assessment. Now, Mark described an assessment that he used there, but what you are picking up on, Brian, is something that I picked up on in the write-up, that I mentioned tracing the irritated neuro back upstream until you find that it's not irritable anymore. And I didn't see direct mention in Mark's write-up about ruling out the spine. So I would agree with you, Brian, that in my clinic, probably what I would do would be to, just like I teach in both the fix your own back and also in the lower quarter NCA course, I'd have the patient by that point in the examination in a prone position, and it's very easy to just do a quick screen on extension and see if that's there, and then stand them up and repeat their index movement and see if that made a change. I might also consider a sideline static opener for Michael Shacklock here, and test that. And I might, dependent on the position, if I'm looking at them with shirt off and I see something that looks like a lateral position, that might clue me into it. And I might directly ask the patient, have you or have any of your friends or any of your docs noted that you seem crooked when your back's particularly painful, like you feel like you're a little bit kicked off to the side or anything like that? And usually I'll get enough information there to start exploring that lateral possibility. I got to tell you, though, I probably, like most of you, I don't want to look too far into that rabbit hole, because I might actually find a lateral presentation I then got to deal with. I hate lateral presentations. But that, yeah, you're right, Brian. Go and do the thing.
My little bit of thought on that, and again, this is a place where I am a little more left brain. It's like when the most common disc presentations start at L34, L45, L5S1, and I'm always doing, poking the spinuses and the interspinal space. And since I studied with Stu McGill, I get to call it a stability test. It's like, does that tolerate being oscillated? And if I find a midline tenderness or a spinous tenderness at the lower levels, I'll definitely try extension and see if it changes the tenderness. I get lazy about getting the person back up and checking their index movement, but I'm absolutely looking for, does the tenderness change? And when people are somewhat antalgic, you're going to want to use, a McKenzie side glide. And I love that lumbar neuro opener from Shacklock. That seems to be really, really useful in a lot of lumbar disc things. My most recent one was my sister-in-law, who's a retired orthopedic nurse practitioner, is so skeptical of chiropractic, but she was struggling after doing a bunch of heavy lifting. And when I did that lumbar nerve opener, she got this big grin on her face, and it relieved her pain. And then she just started doing that 3 or 4 times a day, and she got over her nasty probably L2-3 discogenic pain. So I love that stuff. And I think it's great to add all our tools in and try to figure out when to use what.
I agree. I think it's also worth mentioning that consider all of the tissues that are in play when we do a McKenzie directional preference exam or we do a static opener. Just a moment, I'm responding to Brian's question there. So Brian, what you're asking of, do we stack the benefit, look for 30% and then stack the benefits? Yeah, I do something, put an input in, look for a 30% improvement, do another input at another area downstream from there and look for improvement over baseline. Okay, now we're at 50% improvement over baseline and so forth. And then I prioritize teaching the patient how to do these or doing the things first that the patient can do. Since we've got people on here that are non-clinicians like Brady. Brady, good to see you again, bud. Brady's a phenomenal powerlifting coach. But these are things that you could actually, if the person is having that particular pain and you can't use your hands on them because of lack of scope of practice, you can coach them to grab that particular area and do the twist like we were talking about before. But when we do our directional preference exam for McKenzie, if we've got an L3-4 segment that's involved, hence a femoral derivative that's coming off of there, what side of the body's that on? On the front side. So when you do a prone press up, think about the effect on that part of the body for all of the things that Marc wrote up on in this particular case presentation. Think about the effect on the abdominal wall of those interface points between the anterior femoral cutaneous, the lateral femoral cutaneous, the iliohypogastric, and the ilioinguinal nerves, all in the abdominal wall when you do a prone press up. So are we working the spine or are we working all the other? And here again, we could just be trying to put on pointy hats here that we don't really deserve. But at the end of the day, we can look at that and say, okay, did that make you feel better? All right, do it. Just do it. Is there any risk? No. Does it cost anything? No. Then do it. Feel better. Let's see, Jerome, I see you over there. I can see you thinking, Jerome, because you're rolling that model around with your camera on. You want to show us a model. What do you got, brother? Unmute so it
Oh, I thought maybe it'd just be helpful to with the static opener. Marc had that response from that ortho nurse practitioner. I just wanted to show people the dynamics of that IVF and, a subtle change in rotation, right? Because the static openers basically take the lumbar spine in a flexion. You can see the IVF here, right? Take the lumbar spine in a flexion. And if there's something that's being encroached, vascular elements around the nerve, a static opener with some rotation will just free up. And it could be just a couple millimeters enough to help with the, the elements around the nerve. So that's all I was trying to, I didn't want to be center stage. I just wanted to be on the sidelines here to help.
No, you're perfectly appropriate. Thank you. But I would add to that as well. I just had a patient this past week that had a version of this, and one of the places that she particularly had pain in that anterior hip was while she was driving for a long period of time. So part of what we did, since she had to drive, was to try to imagine that position that Jerome just pointed out while she's driving. So I had her do a little bit of flexion there. So slip her butt just a little bit away from the seat to get that flexion. And then we modeled in the clinic for her how to put a towel underneath one ischial tube. So subtly tilting the pelvis laterally. And then I said, you could either put something there under that butt cheek in your seat, or if you got a bucket seat in your car, you can slip your hip over to the side on the bucket seat. She came back in the next week and was like, that was money. That really, really helped with the prolonged sitting while I'm driving. That, boy, that was a nasty one too. She literally came in, pitched over, and could not stand up. I had 2 of those in 1 week, and I could not get them upright, both of them, using all of my shuck and jive. And I think it might be the first time, and since I've been doing this, that I wasn't able to get the patient upright walking out of the door. So, yep, they're out there, folks.
You know, I remember when I first took Michael Shacklock's course, and because I have a flexion intolerant back, I, for a very, very, very long time, was so stuck in my own extension and so unable to use my abs properly. And Shacklock pointed out that if you're trying to open an IVF, flexion helps to open the IVF. And it was like a big aha moment for me. And I started incorporating that sideline lumbar opening, because it works great for some people. And it's a very easy thing to test. So
hopefully the background noise here for my neighbors, yard crew is not too much. Are you guys hearing that while I'm talking? Okay, then the noise cancellation's working good. Well, as Shacklock was noting, there is a flexion point where you tilt forward just a little bit, and that's that characteristic antalgia, forward antalgia we see in our disc patients. But what happens if we then, in that standing exam, have them to bend forward a little bit more? And they're like, oh, no bueno. There it is. That's down the leg. And what we think is going on there with that is then, and Jerome could weigh in on that, is that dependent on the age of that injury, the age of the patient, and all that stuff, then we could probably imagine that that forward bending is going to result in a hydraulic effect and get a disc bulge to further push on that nerve root. There's a sweet spot right there in between those two. Now, for what it's worth, Mark, I've got that same injury, right? That's part of what kicked me off on this process 25 years ago. My first year in practice, I herniated a disc in my back. And now at ripe old age of 61, I don't have any flexion intolerance anymore at all, but I've got extension intolerance, and it's right there. As it turns out, my herniation was an odd one, weird position that it occurred in, and it was an upper lumbar. And that particular segment, what I do now and what I've found really helpful with patients is working on flexion and sagittal plane, reducing the amount of compression. So I'll have a patient in supine. We'll start off with log rolling to see if they can tolerate that. If they can tolerate log rolling, we use that to coach right position. Brady knows this from the stuff that Kabuki used to teach in the courses there, and a breathe and embracing for the progressive loaded movement courses. That is right position. Get the thoracopelvic canister stacked, diaphragm over the pelvic floor. So the log rolling reminds them of that position in a safe position of supine where they don't have compression. Then from that position, I'll see if they can tolerate. Now, this is not a hot disc, right? This is well further on down the line, or it's a lumbar stenosis case in an older patient. Then I'll see if they can handle that same position, but with more moment arm. So there I train them or assess them in a hollow body position from gymnastics. Same position, supine, tuck the chin, curl up like you're trying to see your belly button, 6 inches raise of the straight legs from the floor and the arms overhead, and then roll back and forth like you're in a canoe trying to roll the boat back and forth. If they can tolerate that, then the next place, so log rolling first, then hollow body. The next thing is a 5-month position in supine from DNS. So there you are, and what some of you might see on Anteo, or what you saw previously in a Craig Liebenson course or on my rehab as a wall.
Our money, it's my money, and then
Jerome, you mute that. There we go. That supine position of I believe it's one of the wall bug progressions. So that's bringing the legs up a little higher than they were in log rolling, a little more extension in the knees. They're still bent, but a little more extension. And then you just have the patient get their sacrum off of the floor. And the way that I'll have them to remember that is I'll say, let's imagine we have a mouse problem in the building where we are. Mice like holes to climb into. Don't give them a hole to climb into. And again, you use a little bit of vulgarity, something that's a little bit risque, but not too off color, and your cues stick. The patient will never ever forget that. Then they hold that position, keeping their butt off of the floor, and I'll lay right there beside them and do it. And hold 5 seconds, come down. Rise, hold 5 seconds, and come down. It will cook your lower deep abs. And then from there, so now we have log rolling to hollow body to DNS 5-month position. Then I'll progress them up into plow pose from yoga. And we'll explore going all the way up and over to as far as they can go, and then have them kind of rest at that far end position, and then come back down in super slow-mo on the eccentric, getting in touch with each spinal segment. Can you feel segmental movement? And you can lay there right beside them and see there's 2 or 3 segments that are moving as a block. Okay, can you feel that? Assist them, get back up again. Let's play right there. Get your kinesthetic awareness on that and see if you can feel that right in that particular area. What I meant by eccentric there, Brian, is the negative rep when they're coming back down. So the muscle under tension is lengthening.
Philip, that was a beautiful 4-part exercise thing. Do you have a video of that, or could you post a video of that to the site?
I've put it together on my, I've got the Anteo app, which is my old library that I've licensed to that company, and it's and you can get it there for a discount for your first year because of your association with me. That's in your NCA notes, by the way. It's at the end of the course, right at the end of your notes, that code. But all of those individuals are in there. And the cool part about the Anteo app is you can take your own phone out. You can record yourself or just record a model doing all of those things and upload that video to your Anteo account and serve it to your patients that way, directly to your patients. So in direct answer to your question, I don't have that flow laid out, but what I've done is take those individual videos and I put them together as a program on that from the library on Anteo, and then I can send the program to the patient. Or, I'll do the same thing that most of you have already doing, and this is why I didn't spend the $30,000 it was going to take me to rebuild my rehab again. Most of you are already doing this. You take out your own cell phone or your patient's cell phone, and you do the recording of the video of what you want them to do right there. You got a one-off, and the patient's got it on their phone for easy reference.
Yeah, that's a great way to teach.
Yeah. All right. We are an hour into this thing. Anybody got any closing remarks?
Philip, I just want to thank you for the opportunity of allowing me to present this case.
Absolutely. I would like to say as well, I appreciate you guys being patient with me during our hiatus during the summer. It was a break that I needed. During that period of time, I've opened another office. And I needed time to get that squared away. I was able to go on another lovely junket with my wife to Slovenia and Croatia. I highly recommend Slovenia, people. The other things that I'm working on, I've got some interesting AI incorporations into the Fix Your Own Back program that I'd like to get out of the gate in the not too distant future. All of that is to say, and I've got somebody working on actual good old fashioned SEO for the NCA site, so that hopefully we can get some more members on there and get some more courses, in-person courses out there. If you guys want to host a course, let me know. We need, and we'll try to get something together. If you think you can put 20-ish people, 15 or 20 people in a room. NCA itself and the meetings for this weekly is too much. It was nice to see a good turnout today, but having Jerome and Mark as our little Jerome and Mark and Alex and I kind of sitting together in a group reliably every week just becomes a little bit too insular. So I'm willing to do this on a monthly basis, but I'd like to get you guys more involved on this. So you having these cases, when you have them, again, use those of you that came on a little bit later, check out the video on this and what I was talking about of how to take your case note, redacted, PHI, taken care of, and just throw your case note on ChatGPT and give it the framework of a case study to work off of and say, give me a case study out of this. That's not your finished product, but it gets that first bit of writing done so that you can look at it and say, wow, hey, that's pretty cool. And then you're like, oh, well, I also did this, and you add that. And then if you don't know the references, then you just send that stuff to me and I'll look at it and I'll say, oh yeah, well, he's pulling references there off of this paper from Main Syndrome or this paper from Jay Shaw or whatever. And I'll throw the references in there and then boot it back and forth to you. And we'll get something that looks possibly publishable. And if it is, we'll farm it out to a journal, run it up their flagpole and see if we can get some case studies out there in the literature. Cool. Okay. Appropriate use of and ethical use, provided you're getting written consent from your patients before you do that, of the current technology as it gets better for us. I'm finding that AI is a really nice way to get over that first part of the writer's block. It gives you a first copy you can start to play with. Okie doke. You guys are awesome. Thanks for joining, and I will see you the next time somebody throws me a case study and says, yo, what you got? In the meantime, take what you've learned, go help some people, make the world a better place. Cheers.
Thanks.